Welcome to the July 2020 monthly virtual in-service series. This month's topic is Nursing Care for the Premature Infant, a Basic How-To Guide by Amy Joyner, RN. The first question to ask is, what is a premature infant? A premature baby is one who is born too early, before 37 weeks of pregnancy. And premature babies are classified in the following way. A late-term premature infant is born between 34 and 36 weeks. A moderate preterm infant is born between 32 and 34 weeks. A very preterm infant is born at less than 32 weeks. And an extremely preterm infant is born at or before 25 weeks. Each year, about 1 in 10 babies in the United States is born prematurely. Premature babies may not be fully developed at birth. They may have more health problems and may need to stay in the hospital longer than babies born at term. The earlier in pregnancy a baby is born, the more likely he is to have health problems. The good news is that due to advances in medical care and technology, most babies born prematurely are more likely to survive and thrive today than ever before. What does a premature infant look like? A preterm baby can look very different than a full-term baby. Most of the baby's systems and organs are affected by preterm birth. During this presentation, we will discuss common medical concerns in premature infants and nursing interventions. In this presentation, we will discuss BPD, Bronchopulmonary Dysplasia, RDS, Respiratory Distress Syndrome, AOP, Apnea of Prematurity, PDA, Patent Ductus Arteriosis, ROP, Retinopathy of Prematurity, IVH, Intraventricular Hemorrhage, Neonatal Sepsis, and feeding difficulties in the preterm infant. Bronchopulmonary Dysplasia, BPD. BPD is a chronic lung disease that can develop in premature babies and babies who have been treated with a breathing machine. Babies with BPD have scarring or swelling of the lower lungs, the alveoli, and are at a higher risk for lung infections than other babies. Ventilators and oxygen are often essential to survive for preterm infants, but over time, the pressure from this ventilation can injure an infant's delicate lungs. What can you do when caring for a baby with BPD? Often these babies require oxygen, ventilators, and pulse oximetry. Oxygen and ventilator support may be needed for months or sometimes years. When caring for your patient, make sure to follow MD orders for specific oxygen settings, vent settings, and pulse oximeter parameters. Decreased oxygenation in infants can decrease the growth and stress the heart and lungs. These babies are often on medications as well. One type of medication is a diuretic. This decreases the fluid that can build up in the lungs due to a baby's inability to excrete excess fluid due to these damaged lungs. Bronchodilators are often used. They relax the airway muscles during breathing spasms and wheezing. And lastly, anti-inflammatory medications. These can decrease the swelling in the airway. Respiratory Distress Syndrome, RDS. This is a serious breathing problem. It can happen to premature babies who are born before their lungs are fully developed at 37 weeks. Normally, a baby's lungs make a substance that helps the lungs fill with air, called surfactant. The lungs usually make this substance close to the time of birth, 37 weeks, and it gives lungs elasticity and keeps the lungs open. If a baby's lungs did not make enough surfactant, it is very hard for the baby to breathe. Artificial surfactant is often given through a breathing tube to treat lungs with RDS. This treatment is done initially after birth. Some babies may have complications from RDS. Some long-term complications may be BPD, kidney failure, blindness, and intellectual disabilities. Supportive treatments for babies with RDS entails oxygen therapy and pulse oximetry, assessment of vital signs, assessment of breath sounds, and good nutrition to support growth and overall health. Apnea of Prematurity, AOP, This is a pause in breathing for 15 to 20 seconds or more. It may happen together with a slow heart rate called bradycardia. This is most often due to a premature central nervous system, which is the brain breathing control center. Treatment and nursing considerations for AOP. Symptoms of a baby that has apnea of prematurity may be bluish color to the skin, cyanosis, a decreased heart rate, and low oxygen levels via pulse oximetry. Care of a baby with AOP may require an apnea monitor. General care requires controlling the body temperature, proper body positioning, and extra oxygen as needed. Some babies require nasal CPAP, which provides a steady flow of air into the lungs. And lastly, there are some medications these babies may receive. One is theophylline, and it's a bronchodilator that stimulates the infant to breathe. Patent ductus arteriosus PDA. A PDA is a heart condition that happens when a blood vessel, called the ductus arteriosus, doesn't close properly. The ductus arteriosus helps blood go around a baby's lungs before birth. When a baby is in utero, blood bypasses the lungs. Once a baby is born and her lungs fill with air, the ductus arteriosus isn't needed anymore and usually closes on its own after a few days. If it doesn't close properly, too much blood may flow into the lungs. Poorly oxygenated blood may flow in the wrong direction, which may weaken the heart muscle and cause heart failure. This can cause heart and breathing problems. Symptoms and treatment of a baby with a PDA. A baby who has a PDA may have poor eating and poor growth. They may have sweating and crying while eating, be fast breathing or breathless, tire easily, and have a rapid heart rate. Treatment for PDAs are the following. Sometimes if a PDA is small, the doctors prefer to watch and wait, as most PDAs close on their own. Medications can be used often to close a PDA. One is NSAIDs and the other is Indocin. And surgery is a last resort. This is where the open duct is repaired using stitches or clips. Nursing considerations for a child with a PDA. If a baby has an open PDA, if you're in the watching and waiting stage, they have a higher risk for infection of the heart. Good oral care is crucial. Infants with open PDAs may also require special formula to support growth. Any infant with a heart condition needs to be monitored for symptoms of heart failure. These can be poor growth, tachypnea, lethargy, sleepiness, and fluid retention. PDAs that have been treated typically need no further treatment. Retinopathy of Prematurity, ROP. ROP is an eye disease that happens when a baby's retina doesn't fully develop in the weeks after birth. The retina is the nerve tissue that lines the back of the eye. ROP usually affects both eyes. Most babies with ROP have a mild case and don't need treatment, but babies with severe ROP can have vision problems or blindness. Nursing care for an infant with ROP. Some babies may need surgery to treat, laser or cryotherapy. These surgeries burn away the periphery of the retina that does not have normal blood vessels. For most babies, however, ROP gets better on its own as the eye matures. About 10% of babies with ROP require surgery for treatment. When caring for a baby in the home, it's important to make sure there's timely follow-up on ophthalmology appointments, keep oxygen saturations in optimal range, and good nutrition is essential for growth and development and reduces the risk of infection. Neonatal sepsis. Premature babies can get infections more easily than other babies because their immune systems aren't fully developed. The immune system protects your body from infection. Infection in premature babies can lead to sepsis, which is when the body has an extreme response to infection. Sepsis can be life-threatening. Home nursing care to prevent infection. The most important intervention is hand wash, hand wash, hand wash when it comes to decreasing the spread of germs. Some additional interventions are ask all visitors to wash their hands, avoid crowds, call the doctor immediately for any signs of illness, ask to be put immediately into an exam room at all doctor's appointments to decrease the spread of germs, and good nutrition overall, which will strengthen a baby's immune system. Intraventricular hemorrhage, IVH. IVH is bleeding in the fluid-filled spaces, the ventricles in the brain. The more premature a baby is, the more likely he is to have IVH. Blood vessels in the premature brain are not fully developed and fragile and can rupture and cause bleeding into the ventricles. If caught early and treated, however, prognosis is good. What can happen after an IVH? Neurologic complications can happen with an IVH. These complications include motor delays, learning problems, and hearing and vision problems. Here are some examples of neurologic complications. Muscles that are tight or stiff, not sitting, crawling, standing, or walking when expected or not at all, frequently arching his or her back, seizures, however these are not common, learning disabilities, hearing can be affected and deafness can occur, vision can be affected and blinding can occur. The most severe complication of IVH is hydrocephalus. Hydrocephalus is the buildup of fluid in the ventricles. This can cause the ventricles to increase in size and results in increased pressure on the brain. Medical treatment for hydrocephalus. Surgery for shunt placement may be needed to decrease fluid buildup. A VP shunt is a thin plastic tube that helps drain extra CSF fluid from the brain and is then absorbed in the abdominal cavity. CSF fluid is the salt water that surrounds and cushions the brain and spinal cord. Nursing interventions for babies with IVH or VP shunts. Most babies with a mild IVH do very well. Babies born with a more severe IVH are at risk for cerebral palsy, seizures, developmental delays, and learning problems. Babies with VP shunts need to be monitored closely for a properly functioning shunt. If a shunt is not functioning properly, you may see redness along the shunt tract under the skin, the baby may be fussy or irritable, they may vomit, and seizures may occur. If you see any of these symptoms, call the physician immediately. Feeding difficulties in preterm infants. Premature birth has many effects on infant health, development, and behavior, and feeding is no exception. Not only can feeding issues cause problems during the first weeks and months of a premature baby's life, it can be an ongoing issue for many families for years thereafter. Feeding issues can stem from a medical condition or a persisting developmental issue, or it can be a learned behavior left over from the neonatal intensive care unit. Gastrointestinal issues such as reflux or poor gastric emptying are examples of physiologic reasons that a baby may have difficulty eating. If gastrointestinal comfort and readiness are not present and a baby's food intake is increased to promote weight gain, this situation can increase physical pain and discomfort that a baby associates with eating. The long-term result of this imbalance can be oral aversion and defensiveness around mealtimes and eating. Some common feeding issues due to prematurity. Difficulty sucking and swallowing. Premature infants are uncoordinated with sucking, swallowing, and breathing at the same time. Less stamina and more drowsiness. Drinking a bottle requires a lot of effort for a premature infant. It is equivalent to a run around the block. Increased vulnerability to infections. Sick babies cannot eat well or digest well. And more respiratory instability. Difficulty breathing equals difficulty eating. Nasogastric tubes and the preterm infant. NG tubes are short-term. Because some preterm infants have not yet developed coordinated sucking and swallowing, they may be fed by nasogastric tube. NG tubes are used short-term until a baby can eat by mouth and gain weight successfully. If a baby is not successful with an NG tube, a G tube is often the next step. G tubes and the preterm infant. Why a G tube may be indicated. Long-term ventilation. Babies who need to be on a ventilator for a long time won't be able to eat. It may take a long time for these babies to learn how to eat well once off the ventilator. Oral aversion. Premature babies in the NICU receive a lot of unpleasant stimulation to their mouths. Intubation, suctioning, and poor feeding techniques can cause babies to develop an oral aversion that prevents them from eating enough to grow and gain weight. Neurologic disorders. Cerebral palsy or other neuromuscular disorders can cause sucking and swallowing problems that make it hard for babies and children to eat enough food to grow well. Difficulty gaining weight. Failure to thrive, BPD, and genetic disorders can all make it hard for babies to gain weight. Putting it all together, feeding, preventing illness, safety, providing individualized nursing care, and general baby care may all be a little more complicated for babies born prematurely. Anxiety is often high for parents of premature babies when they come home after a long hospitalization. Your role as the nurse is to follow doctor's orders and plan of care and to educate and help new families transition into their role as parents of premature infants. Now it's time for a quiz to see how much you know. Please answer true or false to the following questions. 1. Babies with BPD have scarring or swelling of the lower lungs. 2. An infant's lungs are fully developed by 35 weeks gestation. 3. Most infants with ROP require surgery as treatment. 4. Babies born with more severe IVH are at risk for cerebral palsy, seizures, developmental delays, and learning problems. 5. An NG tube is a short-term intervention for a premature infant with feeding difficulties. And 6. What other topics would you like included in upcoming virtual trainings? Thank you for participating in the Maxim Woodbridge monthly in-service series. To get credit for this training, email amjoiner@maxhealth.com when the training is completed. In your email, please include the answers to the 6 quiz questions on the previous page and your name and title. A certificate of completion will be emailed to you. If you would like additional information on premature infants, please contact your clinical supervisor. Thank you again for your participation. Your nursing care is so valuable to Maxim Woodbridge and to the families that we care for.